Hello, I'm Jerry Nolan. I'm a consultant in anaesthesia and intensive care at the Royal United Hospital in Bath, and I'm a member of the AIRWAYS-2 research team. I've had a long-standing interest in CPR, and I'm currently editor-in-chief of the journal Resuscitation, and I'm vice chair of the European Resuscitation Council. I'm going to talk to you today generically about airway management during CPR. And one of the things we need to consider is the objectives of airway management during CPR. Ultimately, what we want to achieve is, of course, return of spontaneous circulation and improve long-term survival. We would hope that our airway management techniques will enable oxygenation and ventilation of the lungs, particularly in circumstances where lung compliance can be very poor, such as during cardiac arrest. We would hope that the airway technique that we used will protect the airways against aspiration. We also want the technique to really minimise the no-flow time, in other words, reduce the amount of time that we're interrupting chest compressions. And generically, of course, we want to minimise the number of complications. The gold standard has traditionally been tracheal intubation for CPR, and there are a number of reasons probably for this role. First of all, it's generally thought to be one of the best ways of enabling uninterrupted chest compressions, at least once the tracheal tube is placed. Probably enables us to provide the most effective ventilation, particularly if the lungs are particularly stiff. And once the airway is inserted, a tracheal tube is the least likely airway to be dislodged. It will minimise gastric inflation and hopefully, of course, protect against aspiration. There are, however, a number of disadvantages to tracheal intubation. We know it's a skill that takes quite a long time to learn, so it's heavily operator dependent. And during the procedure itself, it tends to lead to significant interruptions in chest compression. Ultimately, the big problem with tracheal intubation is that it doesn't fail safe. In other words, we have serious complications of both unrecognised esophageal intubation and bronchial intubation. The other thing is that training and skill retention is pretty problematic. We know from a number of studies that the number of insertion attempts can be quite a lot before we get really reliable first-time success rates. A recent study from Switzerland in first-year anaesthesia residents showed that they required about 50 to 75 intubations before they were getting around 80% first-time reliable success rates. So this is why a potential alternative during CPR is the use of supraglottic airway devices. There are a number of these on the market, such as the iGel, Supreme laryngeal mask airway, and the laryngeal tube, and these are all much easier to insert. They have a number of other potential advantages as well, in that it's not just a question of reduced training time to reliably insert these devices, but also, of course, it's much easier to maintain skills because it's simply an easier skill to use. There are a lot of observational studies now published in the CPR literature that appear to show that overall survival rates may be better with the simplest form of airway technique, such as bag mask ventilation, compared with either tracheal tubes or supraglottic airways. The trouble with all such studies is that they are plagued with confounders. In other words, those patients that are most likely to be resuscitated successfully are probably resuscitated quickly before they need advanced airways. We've got a number of observational studies and systematic reviews that now really are calling for the same thing. They all conclude that we are in urgent need of prospective randomized controlled trials of airway management during CPR. And even some of our American colleagues are recognizing that and are suggesting such a study should be undertaken. And in fact, one such recent review even cited the Revive Airways trial as such a study. Recently, at the beginning of February in 2015, the International Liaison Committee on Resuscitation met to review all the science of resuscitation and to draft both a consensus on science statements and treatment recommendations. There will of course be new guidelines published in October 2015, but we have the possibility of seeing some of the draft recommendations as they stood at the end of February. And the most important one in relation to airway management is that there was suggestion was that we should either be using a supraglottic airway or tracheal tube as the initial advanced airway management technique during CPR, and importantly using the systematic review technique that was in place, the grade system. This was just a weak recommendation based on very, very low quality evidence, specifically for out-of-hospital cardiac arrest. One of the important things that ILCOR does is not just to give a treatment recommendation in that way, but it also cites a number of values and preferences around that treatment recommendation. And it was recognised that the type of airway used may depend very much on the skills and training of the healthcare provider, so it may differ depending on the circumstances. It was also recognised, as we've already said, that tracheal intubation requires considerably more training and practice compared with other airway management techniques. The problem we have in airway research in cardiopulmonary resuscitation is that often multiple airway techniques are used as part of a stepwise approach to airway management, and this is certainly going to make it a challenge to undertake research in this particular area of CPR. So to try and pull that together and to summarise, I think the most important message that we have is that there is no robust evidence for any specific approach to airway management during pre-hospital cardiac arrest. In other words, we have complete clinical equipoise about the technique that we should be using. We've clearly got international expert consensus now calling for randomised controlled trials, and although we recognise the stepwise approach is going to make it challenging to undertake such research, we believe strongly that AIRWAYS-2, I hope, is going to provide us with the answers. Thank you for listening.